So, Isabel, we see these patients, before we talk about chemotherapy options for these patients, which has drastically changed, and I'll go over the data and get your impressions. Anju, your thoughts on another contentious question here, the role of consolidative radiation. Let's say we give this patient before the advent of IO was integrated into the realm, 4 cycles of a platinum doublet, and they're doing well. Consolidate all sites of disease with radiation post-chemotherapy, or maybe?
It's a great question, and our typical practice pattern has been to really focus on consolidation of patients in the traditional manner where they've had an excellent response on any sites of distant disease. If the disease is confined to the thorax, we typically do try to consolidate that disease if they've had a good response to systemic therapy. I think the question is really now changing in the advent of systemic chemotherapy and IO. As you know, consolidation thoracic radiotherapy was not allowed on that trial, and so it's really brought up a lot of interesting questions about how do we manage those patients and in what setting it may be or may not be appropriate.
Yeah, so that's a good segue into the trial. We've clearly had a practice-changing trial with Empower 133, asking a very, as thoracic medical oncologists, we generally ask very simple questions in our trials. We're simple folk. We basically take platinum doublet and then we add something to platinum doublet and compare it, and that's the way things have gone. We've been historically unsuccessful with this, but recently we've been quite successful, both in non-small cell and small cell, which is, beg the question, why let research and science get in the way of progress? Basically just adding a drug to a platinum doublet and comparing it to platinum doublet alone over the past 12 to 24 months has translated into overall survival advantages. So this was extensive stage small cell patients randomized 1-to-1 to platinum etoposide versus a maximum of 4 cycles versus platinum etoposide with PD-L1 inhibitor atezolizumab. Atezo was allowed to be given as a maintenance therapy as well. And I think we were surprised. I think that we've tried this before in small cell, nothing's ever worked. And for the first time, we saw an improvement in progression-free survival. And perhaps more importantly, this was presented at World Lung in Toronto and then subsequently published at the same time. We saw an improvement in overall survival. And we have looked hard and long for survival advantages in small cell and in just such an unforgiving disease. Interestingly, small cell is one of these tumors that we would think would be so sensitive to immunotherapy. It's fraught with mutations. It's heavily associated with smoking. It's rapidly progressing as an aggressive tumor biology. All of the hallmarks of a tumor that should have predict sensitivity to immunotherapy. We didn't see the same benefit that we saw in non-small cell. Nevertheless, we saw a benefit. It was modest, but there. Most subgroups of patients benefited. Interestingly, they did an analysis of tumor mutation burden in the blood to see if that predicted efficacy to atezolizumab. It did not. It seemed, it would be helpful to have some sort of biomarker, but there was no biomarker here that really shook out, that helped us select patients that are going to get this. So everybody gets it now. Isabel, your thoughts on this, and do you see a lot of small cell, and are you using this regimen? I've used it a couple of times. I've got some mixed stories, but thoughts?
So unfortunately, I do see a fair amount of small cell. And I think the Empower 133 data is very exciting because finally we have something in this field that has shown some benefit. And I think in my little experience with this regimen, because it has not been approved for very long, I have had some success with it. And not only does it offer maintenance therapy, but it also helps alleviate some of the anxiety of the watch and wait that the patients have after the 4 cycles of the platinum doublet, scanning them at set intervals to evaluate for disease relapse can be anxiety provoking. But allowing them to be on this regimen every 3 weeks as tolerated has allowed them to feel that they're continually fighting against this disease.
Yeah. No, I would agree. I think that the drug itself is exciting for patients. I think that the maintenance part is important. Before we would tell patients you're getting 4 cycles and then we're just going to watch you, and yes, there's a high likelihood that this will come back pretty quick, but I have nothing to really intervene on at this time. And I think having that maintenance, they've started with it. They are continuing with the drug once they've completed the 4 cycles. any issues with toxicity at all with the drug combined with the platinum doublet?
So fortunately, I have not seen toxicity. I think most of the toxicity comes more from the platinum etoposide, from what I've seen, which is what we've seen before with the platinum etope. The atezolizumab seems to have been a nice addition with limited toxicity, in my experience, fortunately.
Anshu, have you seen, I mean, we're wrestling now with how to, as you mentioned, this trial did not allow consolidative radiation, and we're learning about the role of consolidative radiation even in non-small cell for oligometastatic disease. How do you guys sort this out? Are there still times where a patient could be put on this? If they progress on the atezo, you would then radiate them? Or have you just said, look, we can't really fool with radiation now that we're integrating immunotherapy routinely for these patients?
Yeah, I've had discussions with a lot of my colleagues, and some of them kind of practiced by the book in terms of what the protocol did, whereas others are really saying, well, you know what, we're still dealing with a disease that has a fairly high mortality. They kind of struggle with the question of saying, should I really be withholding something that may also provide a progression-free or an overall survival benefit? And if we look at the recent Slotman data, basically what they've done in the consolidative setting for thoracic radiation has really brought the dose down significantly, closer to about 60% of what the original dose used to be, about 50 gray down to 30 gray. You're talking about 10 treatments, 2 weeks. The question really is can it be given concurrently with the TESO? And I think that that's the real question. I think it's going to depend on the amount of disease, the bulk of the disease, the distribution of the disease, and then ultimately, as we kind of get some data in the real world setting, we may be able to see is the incidence of pneumonitis a risk or not. And then I think we may be able to extrapolate from some of the other studies that are looking at combination of thoracic radiation and IO to see if, you know, radiation therapy given concurrently with IO is really a risk or not.
Yeah, and that's a good point. We were going to have data in the next 2 years looking at concurrent IO with radiation, and I think that will help us feel more comfortable. Now, whether that data will be, you know, a positive or a negative, we don't know in terms of toxicity, but the question really is, can you safely give immunotherapy concurrently with radiation? As it stands today, we don't know. And I think we have good data, at least with targeted therapy. It can be given relatively safely with at least palliative radiation or even whole brain radiation. But for immunotherapy, that pneumonitis toxicity is, I think, real, and I think we need more data.
And I think that either consolidating or local therapy for extrathoracic disease in the setting of concurrent IO, there's more comfort with that.
Yeah.
But I think, again, in the setting of thoracic disease, again, looking at the anatomical distribution and how it might impact some of the dosimetry, those are questions that remain to be answered.